So let's go back to the recording. Welcome to Smart Dog Productions West Florida HCA Webinar Network Case Conference today. And our cases today involve acute pericarditis. In my experience, over 47 years, wow, that's a long time. And so I was going to talk to you about 5 cases that we have today for review. And we're going to show the transition from EKG, chest X-ray, and 2D echo to the addition of MRI and CT. So that's going to be kind of interesting. And so because during this period of time, we had the evolution of technology. So I think our first case is somewhere in like 1972, and then we have another case in 1970, and then we have a case in 2003, and then we have 2 cases that are of recent vintage. So it'll be kind of fun. So let's talk about one of our first cases, and we'll talk about the spectrum, and we're only going to be talking about acute and probably subacute because of the complexity of constrictive pericarditis and chronic recurrent pericarditis. So at a later time, we will discuss chronic recurrent and constrictive. This time, we're going to keep ourselves on the acute viral and acute, subacute, and tubercular and bacterial. And so acute, the workup today is cardiac imaging, echo, MRI, CT, EKGs, of course, and chest x-rays. And so we also have the acute, subacute, chronic pericardial effusion, serial echo, follow-up with intensive therapy with NSAIDs, colchicine, steroid use. Talk about the invasive evaluation and treatment. That is, sometimes we have to do pericardial windows. Talk about tubercular, which I don't see a lot much, and so that's why we only have 1 case from long ago. We can talk about acute bacterial, which I've only seen 1 case of. And so our first case for presentation is someone we saw back in 2003, and this was a 45-year-old African-American male janitor who actually worked at the boat dock at MacDill, presented to MacDill. This certainly dates it because he presented to MacDill Air Force Base Hospital, which currently doesn't exist. There's a clinic now. Huge clinic, but there's a clinic. He was transferred to Memorial Hospital. He was diagnosed as having a cardiomyopathy, and he was started on Lovenox, which was a frequent occurrence. He had 3 or 4 months of anemia with colonoscopy, history of hypothyroidism for about 3 months, had been recently started on Synthroid, had fatigue, which had been occurring for this 3-month period. He developed a cough with white mucus. He had a fever, which he treated personally with goody-goody powder. That's a home remedy. And shortness of breath, chills, positional chest pain, increased with inspiration, couldn't sleep. And so shows up here with a fever of 101.2, respirations are 18, blood pressure 144/85, his heart rate was commensurate with that, being about 100. He had a pericardial rub on exam. There was a to and fro rub that sounded like a creaking saddle if you've ever been an equestrian. Sounds like when you're riding on a horse and the saddle's creaking and you hear this sound that's kind of leathery. He also had a chest x-ray that showed an increased pericardial cardiac silhouette, and it's kind of globular, looked like a shmoo, which was a character in the Little Abner series. So his EKG and echo, his EKG showed characteristic classical diffuse ST segment elevation of multiple leads. We'll show you an example of that as we go on. It's not to be mistaken for an acute MI because of the lead systems involved. It would have to be a massive acute MI involving everything without reciprocal changes. And so that doesn't make any sense. And so we'll show you why that doesn't make any sense. And he had a large pericardial effusion, which is a good reason not to be on Lovenox. He had LVH, probably because he's had long-standing hypertension that's not been diagnosed. He had a sinoatrial tachycardia. His ANA was negative for collagen vascular disease, rheumatoid factor was negative, and C-reactive protein was negative. MRI and CT was not clinically available at Memorial Hospital at that time. We had just started moving into that program, and it took us about 13 years to get everything complete the way we want it, and now we're adding on another $1 million worth of stuff to make it even better. The plan at that time was obviously to discontinue Lovenox because he could bleed into his pericardial sac and get tamponade because he has an inflammatory reaction there. ID comes to see the patient, and we can talk about whether ID is of any use or not. Cardiovascular surgery consult, and that's usually to consider, maybe we ought to take some of this fluid off for diagnostic reasons. Maybe we ought to create a window so that the fluid drains into the chest cavity, into the pleural cavity, and that we don't have the potential for tamponade. And maybe we can get that fluid out of there and it won't keep weeping as the patient gets induced on steroids, NSAIDs, and colchicine. And colchicine was the latest addition in the last 20 years to the anti-inflammatory armamentarium. This patient had a white count of 11,800, a SED rate of 22, not very elevated. The B-type natriuretic peptide was greater than 100, and 100 was the cutoff for normal. It was 109. 2003, there weren't a lot of BNPs floating around, and actually we were the first hospital in the United States to start using BNP, and we would get queries from Tampa General and St. Joe as to what this new thing is, this BNP. And we had so many questions that we had to put it up on the website. And we put up our experience of BNP, and our experience with pericarditis was that the BNP didn't go up much. And so that was interesting. So this was one of our first experiences with BNP. The ID consult did a workup for things we never see. Coxsackie virus probably is responsible for some myocarditis. There's a viral panel consisting of St. Louis encephalitis and several other Eastern equine encephalitises and other things. Mycoplasma was checked on for acute and chronic titer, chlamydia, candida, of course the urinary culture sensitivity, blood cultures, all of which were negative. And these things come back when you order these panels. They'll come back in maybe 6 weeks to 2 months from somewhere where they outsource it. And it is usually of no use because the clinical situation is over and the patient's doing fine. So I'm not sure if the ID consult is a valid thing to do nowadays, but we certainly did that then. Cardiovascular surgery consult is depending upon how much fluid there is, and if we feel that it's semi-gel or if we feel that it's stretching rapidly, and if we feel that there's some hemodynamic compromise, then, or if we just think that the fluid's not resolving even though the patient's on steroids or non-steroidal anti-inflammatory drugs or colchicine, it's not going away, then at that point we consider cardiovascular surgery. In those days with a window, nowadays probably what we would do is take the patient to a CT scan and get someone who's really good at it, who's an interventional radiologist, to just drain the fluid and either leave a drain in for a while to drain the pericardial sac, or take the drain out and wait and see if the fluid reaccumulates. Another alternative is to take a Criticon balloon and you put the catheter in, then you blow the balloon up inside the pericardial space, and then you pull it and pop the pericardium so that you make a little window with the balloon. And so those are all different techniques that have been used to try to resolve that particular issue. In a minute we're going to show you, and we have our student Luke Russell with us, who's going to show you an acute viral case, another acute viral case, and then a case of acute and chronic pericardial effusion with acute, subacute, and chronic. But let's go on to some of the more exotic cases I've seen and talk about those for a minute, because you're not going to see much of this, but I only saw one case, and this was in 1969, a 47-year-old African-American longshoreman from working at the Tampa docks, presented at Tampa General Hospital in late afternoon with an acute febrile illness. He was very sick. We put him in isolation in the ICU. He had shortness of breath, weight loss, malaise, nausea, decreased sensorium. He was in a fog. There's a history of heavy alcohol abuse, not particularly at this point, but a history of having that. His physical examination revealed a guy that looked really sick, in acute distress for sure, with tachycardia, fever, distant heart sounds, increased respiratory rate. He was a thin African-American male and didn't look very good. And so we took all the resources that we had in 1969, which we really weren't doing echo other than an echo that was used for looking for brain shift in patients with subdural hematoma. And that was an echo that used only A mode, which nobody ever sees anymore. And we were using that experimentally to get familiar with an ultrasound process of the heart. And all we could see is like the mitral valve moving. And it looked like grass because it was green on the oscilloscope. And so that was of no use to us. But during our 12 hours, it seems like house because we had a resident and interns, and I was an intern. And we were doing everything we could to look at this patient, and we were actually in the lab ourselves looking at the urine sample and looking at blood smear, and we wound up getting some pericardial fluid where we put a long spinal needle in the pericardial sac with an EKG hooked up to the side of the needle. Very primitive technique. It was hooked up with an alligator clip, and so you're monitoring, and when you touch the pericardium, you can see what's going on. You can touch the myocardium, you get changes on the EKG. So, but we were going in trying to just do this blindly, monitoring an EKG. So we did get some fluid, and we did look at it in a microscope and stain it, and we saw the tuberculous bacillus that stains red. In those days, they were called red snappers. So we saw the red snappers. That's not just indigenous west coast of Florida. We saw them on stain. The fluid had been spun down, and we began very aggressive tuberculin therapy. In those days, there was tuberculosis sanitarium that was not very active anymore, where their principal therapy was to collapse a lung and try to kill the active disease by collapsing the lung, making no oxygen available to it. So the patient did survive and walk out of the hospital, and I do remember several years later he was in the same ICU in the same bed at Tampa General with acute pancreatitis that he died of. And so not a very good ending, but a very complicated story and a very difficult diagnosis to make at that time, something that we probably won't see much. And then acute pericardial disease from bacteria is very unusual, and we had a 62-year-old female presented to MacDill Air Force Base Hospital, which was existing in 1972, with acute febrile illness and very high fever that wouldn't go away. Everything was cultured, and broad-spectrum antibiotics for that day were started, and the patient went into shock and died, and the autopsy showed purulent bacterial staph pericarditis. How this happened to be and how this patient got this, I can't tell you. But that's the only case I've seen. It was a terrible, very rapid course demise of this patient. Let's go on and talk a little bit about the anatomy. And so this is a representation of the heart. And we're interested in the layers of the pericardium. And we've got the serous pericardium, has an inner visceral and outer parietal layers. Visceral layer is actually adherent to the surface of the heart, or the epicardium, extends to the origin of the great vessels, where it becomes the parietal layer and is fused with the fibrous pericardium. And then there's a cavity that actually exists with maybe 15 cc's of fluid normally, and not just a potential cavity, but an existing cavity. And we see that all the time on echocardiogram, where there's physiological fluid that's present between the layers of the pericardium. And then there's a fibrous pericardium, which is a little tougher, and it's the outermost layer of pericardial cavity, fused with the parietal layer of the pericardium and attaches to the diaphragm and sternum. And so that's how the heart is attached. And so, pericarditis can lead to scar tissue and fibrosis and attachment to the sternum, where if you were entering the heart through and installing through the sternum, you might actually have an adherent heart to the sternum and saw into the heart as you went through the bone into the chest cavity. So, and we frequently, with open heart surgery, would find the existence of old pericarditis, where there's a bunch of scar and you can't find the epicardial coronary arteries, and so that's something that you pop across when you're doing open heart surgery every once in a while, and you have to search out. It's not just fat, and you got to search out the epicardial vessels to do bypass surgery. So it's a potential space. Here we go. We got 15 to 50 milliliters of pretty clear-looking straw-appearing fluid. Usually there's no blood in it. If there is blood, it's traumatic. So this is not something you'd be tapping because the space is almost non-existent, and so there's not going to be a space when you put a needle in. And here's a little thing showing you these layers again. Here's the heart chamber. Here's the endocardium. Here's the myocardium. Here's the pericardium, the visceral layer. Here's the pericardial cavity. Here's the parietal layer of the serous pericardium, and then the fibrous pericardium. So these are layers that you see. And the pericardial cavity is here. It bends on itself, and this is where you get the fluid. And so the definition is inflammation of the pericardial sac. Sometimes there's involvement of myocardium, called myocardial pericarditis, or actually with rheumatoid heart disease and acute rheumatic fever, which we never see either, you would get a pancarditis that would involve the pericardium, the myocardium, the epicardium, and the endocardium, and the valvular surfaces. And so acute rheumatic fever is a pancarditis, frequently involving pericarditis, but we don't see that. Diagnostic criteria: typical chest pain, which we'll talk about in a minute, pericardial friction rub, which is that creaking lather type sound that I talked about, typical EKG changes, which will show an EKG with diffuse ST segment elevation across multiple coronary regions. And so instead of being acute inferior, like an acute inferior wall MI, or acute anterior, it's acute inferior, anterior, lateral. And so everything has ST segment changes, and there are no reciprocal changes. And so, and then fluid around the heart seen on echocardiogram, because that's what we do on anybody who has a heart issue gets an echocardiogram. And so we have 5% of emergency department patients present with non-ischemic chest pain or found to have acute pericarditis. And so we've got this breakdown of 50% of patients with chest pain coming to the ER. We're not really sure what's wrong with them, and they may not even get a diagnosis before they go home, but they rule out with negative troponins, negative EKGs, and have a low prevalence of heart disease by ruling out with those things, negative echocardiogram wall motion. And so, and then we have like 12% of people that are there with either a STEMI or non-STEMI or acute coronary insufficiency. And so those are the ones we're trying to sort out, and we bump into this little group with EKG changes, and hopefully they didn't get pre-hospital injection of medications for an acute STEMI, because they have been mistaken for a STEMI. And it is true that I read a case in Israel. The ambulance intercepted somebody with pericarditis and got a 12-lead EKG and mistook it for an acute coronary syndrome as a STEMI and treated the patient for a STEMI, and they were using TPA pre-hospital, and the patient got a big tamponade of the pericardium and had to have emergency treatment of the pericardial tamponade. So acute pericarditis involving pericardium, recurrent, constrictive, these are all the different things that happen. Most cases presumed or confirmed are viral in origin, and we really don't do a lot in a workup anymore. It can be a presentation of somebody with rheumatoid disease who has rheumatoid arthritis but hasn't had the onset of the arthritis yet and presents with pericarditis. It can be the presentation of lupus, and can be an early first presentation of lupus. So that can be a fooler. So we're always doing acute workups for collagen vascular disease, and usually include in the workup an ANA, rheumatoid factor, certainly a SED-rate, C-reactive protein, and we're looking for those things, anti-DNA. And so the etiology most commonly is idiopathic, which is basically acute viral, and but the viral serologies are low yield, and most commonly it'll be viral in origin, and then the autoimmune, which we see all the time. Lupus very frequently have pericardial effusions back and forth. Anybody who's been on the renal service will see uremia and pericardial rubs and pericardial fluid, very frequent. This group, there have been reported when someone is actually doing a needle into the pericardium to get a vasovagal reaction, and if the patient has been on dialysis and has been ultrafiltrated and is hypovolemic, they can get asystole and vascular collapse, and so that's something you worry about and have atropine readily available to counter that. Metastatic cancer is you get a bloody pericardial effusion that's not traumatic, and so breast cancer is not infrequent because it's metastasized to the pericardium and to the heart. And then a recent MI, we get this so-called post-cardiotomy syndrome, where after an MI or even after cardiac surgery, patient has a pleural pericarditis, comes back to the hospital complaining of pleuritic type chest pain, very severe pain, and basically have that happen a lot on people who have some kind of open heart surgery, go home from an open heart surgery, and they've been home for 3 or 4 weeks, and all of a sudden they think, oh my goodness, something's happened, and they wind up back in the hospital, and no one knows what's going on because they may have had surgery at a different hospital, and frequently it's not diagnosed. We've also seen the post-cardiotomy syndrome in people who've had atrial fibrillation ablation, and that's a new origin of post-cardiotomy syndrome. And everybody wonders what this person's doing with a couple pericardial effusions and some pleural effusions, elevated SED-rate, and treating them for congestive heart failure or something else, and it turns out that it's not. It's a post-cardiotomy syndrome. And so patients' presentations are so different. Sometimes you can get the history of the upper respiratory infection, and you talk to them and they say, yeah, I had a cold, or had a flu 2 months ago, and so you can trace that back. Seeing them with a fever is unusual, and with leukocytosis and a fever like the case I showed you, and the autoimmune process is always checked for. BUN is important if it's a chronic renal patient. And then chest pain is so common as one of the presenting findings. Whether the pericardial rub is there or not is usually not heard so often. And I have trouble finding somebody with a pericardial rub to show our students. But frequently you can get them to sit up, lean forward, take a deep breath, blow it out all the way, and then listen to the anterior chest carefully, and you may hear diastolic or systolic rub. It may be both to and fro, diastolic and systolic, and it certainly sounds different from a murmur. Sounds like you're rubbing sandpaper against sandpaper. And so it's certainly described well as a rub. And so the chest pain is usually very much positional, and they sit up and lean forward and it goes away, and they lie down and it becomes terrible pain. And so they'll be here in the emergency room leaning forward over the little stand that they had to put the trays on. They'll be leaning forward on that, getting relief from their chest pain. And so you see that all the time, and they're in a position of comfort. The friction rub is these non-compliant layers that are rubbing together, and you can hear it. I hear it at the apex more common, the left sternal border. I usually hear it at the apex. And of course the pleural rub can be distinguished because the pleural is due to taking a deep breath. A venous hum sounds a lot different, which occurs in young women usually, and comes and goes and is related to respiration. and the diastolic murmur heard is totally different than a friction rub. The friction rub having deeper sounds and creaking sounds and sandpaper-like sounds. And so, well, yeah, you press the diaphragm of the stethoscope on the chest. You got to make sure it's not the heart moving sort of the skin against the diaphragm. So you can get that with an active apex and think you have a rub. So you got to really press the stethoscope hard to make sure that you're not getting skin activity rubbing against the stethoscope. And so I've never had the patient kneel on all fours. That would be kind of peculiar to be seeing that in the emergency room. But leaning forward is adequate. And holding and taking a deep breath and then relieving it and then listening to them after forced expiration with a deep breath hold. Of course, it's noisy in the ER, but you can still hear it. Sometimes you hear the little soft ones, and that's people that are getting better. And then people with fluid aren't going to have a pericardial rub at all. So you're not going to hear it. The diagnosis is frequently dependent on more EKG with diffuse ST and T wave changes, certainly more with echo, and then a presumption that this may be something that you have in your differential diagnosis. And then as time goes on, they start flipping their T waves, and their EKG ST segment elevation looks a little different, and so it's evolving, and then they can wind up with persistent T wave changes, but are a normal EKG. But there's some evolution of the EKG during the treatment period and during the stages of pericardial disease. But let's pop over here and look at a characteristic EKG. So here we go. We've got ST segment elevation sort of everywhere except AVR. And AVR, if you flipped it over, it would be ST segment elevation. Since AVR is looking in the opposite direction, from the opposite direction, it's going to be ST segment depression. And so you can see how prominent this is. And so this could look like early repolarization, but you usually don't see 1 and L like that. And so it's all lead systems. And we've got time and time again, this has looked the same. And then, of course, a STEMI occurs frequently with Q waves. If it's very early in a STEMI, you're not going to see diffuse changes. Sometimes you see like an LAD that gets the anterior wall, the septum, hooks the apex, and then goes along the inferior wall. So you have inferior, anterior, and septal changes in the EKG, but it's still not as diffuse as what we're looking at. And so it's not going to be the same. It can be mistaken when you get to some T-wave inversions and hyperacute, but you're not going to get hyperacute changes. You're not going to get QT prolongation, and so because of its diffuseness, you can tell the difference. And so looking again and seeing, when you see what thinks you might have an anterior inferior wall MI, you say, oh, look, it's an LAD that's supplying the anterior wall, the septum, so this would be septum, this would be anterior wall, and then the lateral wall, okay, pretty extensive MI, and they say, well, it's hooking the inferior wall and going in the inferior interventricular sulcus, the LAD is, and supplying maybe a third of the inferior wall as it hooks around the apex, giving inferior, but then you go up here, and this clinches it. You see ST segment elevation 1, some over here in L, you know, hey, this is pericarditis. So even the most preposterous confabulation of anatomy in the LAD is not going to produce this kind of EKG. So even if you're going down, you're saying, okay, anterior, okay, septal, well, maybe a little bit lateral, and then inferior wall, because of the LAD supplying a third of the inferior wall, where the PDA from the right supplies 2/3, And you say, okay, I've got that. And then you say, oh no, that can't be. So then it's pericarditis. And so the lab tropes are usually not positive. B-type natriuretic peptide is minimally elevated. Of course, the uremia, if it's a kidney patient. Leukocytosis, in the patient we presented, there was a white count of 11,000. Inflammatory markers, well, not much, because we can go back to our original case, and you can see, well, ANA was negative, rheumatoid factor negative, C-reactive protein was negative, and then in our original case, there was a SED rate that we saw, like in this case, of 22. So that's not much at all. So you're going to be very disappointed if you're looking for an elevated SED rate. The white count, 11,800. So yeah, unless you have a rip-roaring bacterial, what you're never going to see, you're not going to see much in the way of white count changes. And so let's go back and look at pericardial thickness is 1 to 2 millimeters, which we measure on the CT scan and the MRI. A fibrous pericardium has a lot of fiber in it, is easily visualized. This is the amount of fluid that's usually present. We see it pretty often on the echo. Pericardial fat can also be seen in the same area, and it looks like a clear space. It has the same density pretty much. And then we've got some pericardial effusion presentation that's seen and the frequency seen with pericarditis, and you can see that most people with pericarditis don't have much pericardial effusion. Most of them don't have tamponade. Maybe it's something we did like Lovenox or aspirin. Most of them don't have serious sized pericardial effusions. And then we see pericardial thickening. Really can't tell much about that on the echo. You need MRI or CT. The pericardium is so thin that it's easy to spot a thick pericardium, and it's very easy to measure it too. And of course, malignancy, you can get not only thickening, but you get some tumor cells that are actually growing, and so you big thickening of the pericardium with that, especially with metastatic disease of breast cancer. And so the echocardiogram is, I always take it with me in the ER when I go see a patient with chest pain. I go first to the echo room, pick up the echo machine if it's not staying at night in the ER, and wheel it with me to the ER. I've tried the handheld ones, but they're not good at distinguishing regional wall motion abnormality. So I need the real echo machine to get the kind of differentiation that I want. And so obviously you put the transducer on. Some of the ERs have an echo machine hanging around. It's usually a general echo machine and not cardiac. And so you can use that and see pericardial fluid. You can use the handheld echo and see pericardial fluid, but I'm bringing the big machine because I want to differentiate wall motion abnormalities. And so then you can see pericardium, you can see the fluid, you can see stuff in there that's like strands of stuff. Some people get pericardial fluid that's like between a fluid and a gel that's beginning to change its composition. And so, and you can see the difference obviously in the pericardium, that it doesn't extend into the descending aorta area. There's no large collection back there, so you know it's not a pleural effusion, and you can see it's not in a pleural space at all. So you got to be able to differentiate pleural space. Okay, and so we have some cases we'll show you here. So let's look at some anatomy with more sophistication. So hang on just a second, and then we're going to make Luke Russell our presenter for a minute. He's our medical student on the service. So Luke, if you hang on here for a minute, we'll get you on the mic. So make presenter Russell. Okay, we should be seeing Luke's screen, and I'm handing the mic over to Luke. Luke, here you go. And we see you on, you're on now. Okay.
Yes, good morning. So this was a patient seen across the street at Tampa Memorial Hospital. She was a 57-year-old, let's get this up, 57-year-old hospital case manager who presented to the emergency department on the 13th of July with right-sided chest pain, which she described as 10 out of 10, radiating to the right jaw and left chest. The pain was of sudden onset while she was at rest and progressively became worse to the 10 out of 10 with which she presented. She also had some shortness of breath and weakness, and the pain was made worse by deep inspiration and movement. She attempted to take ibuprofen, which did not help, and she didn't have any prior episodes similar to this. She denied any cough, nausea, vomiting, dizziness, lightheadedness, or syncope. The only pertinent prior history was that of hyperlipidemia, and she had no other major history of medical illness, surgical history, distant and non-pertinent. And socially, she smoked for a couple of years, 3 to 4 cigarettes a day, but quit a long time ago, denies drug use, and uses alcohol occasionally. Family history positive only for diabetes. So on arrival, her heart rate was found to be 118, BP 137/87, respirations 20. She appeared well and was in no acute distress. So physical exam was basically remarkable only for tachycardia. At that time, 115 beats per minute, and her rhythm was regular with normal heart sounds. Initial labs were performed. Blood chem, liver function, and coag were all within normal limits. However, her white blood cells were found to be elevated at 15.3, with absolute neutrophils also elevated at 12.7, and troponins found to be negative, and her blood lipids confirmed her stated history of hyperlipidemia, which was not treated, by the way. She was on no medications. Initial ECG showed sinus tachycardia with possible left atrial enlargement. A chest x-ray was also performed and found to be normal, and then a repeat ECG was consistent with the initial, still having sinus tachy. So CT angio of the chest was performed with contrast to rule out any possible pulmonary embolism or aortic dissection, and that was indeed negative, and the lungs were also found to be clear. So she was given...
And they would have seen the pericardial effusion.
And they would have seen the effusion. She was given ketorolac and aspirin, and after 2.5 hours, she had improved, stabilized and improved, and was discharged home with a presumptive diagnosis of acute pleurisy, and basically instructed to follow up with her primary care provider. 9 days later, on the 22nd of July, she was climbing the stairs at work, again in the hospital where she works as a caseworker, and she began having a sudden onset of palpitation, shortness of breath, lightheadedness, and dizziness. And because she was already in the hospital, she reported immediately to the emergency department. And again, she hadn't had any similar symptoms to this in the past. The presentation here did not exactly match her prior presentation. And she reports that she had been exercising regularly at home without any issue. However, she did admit having recent low-grade fevers and a non-productive cough of about a month duration that had since resolved. At this presentation, she didn't have any chest pain. She denied GI symptoms, syncope, or muscle aches. Vitals at this time were found to be 165. and her rhythm was now irregular. Blood pressure 142/88, respirations 18, and again she was well appearing and no acute distress. Breath sounds were normal and equal bilaterally. So at this point, presumptive diagnosis was made of acute onset atrial fibrillation, new onset. Again, some labs were drawn. White blood cells found to be 11. At this time, she had a D-dimer found to be elevated at 2.36. This was presumed to be related to her pericarditis. Other coag studies were negative, and she had slightly low potassium at 3.3. Serum creatinine was found to be normal, and she had some elevation in her LFTs. Troponins, again, were negative, and thyroid function was normal. Okay, we can go ahead and flip over and show an image.
These are really beautiful pictures. As you can see, here's the left ventricular myocardium, normal left ventricular contractility. You can see the mitral valve. You can see filling through the left atrium and the pulmonary veins, through the mitral valve in the left ventricle. This is a 4-chamber view. You can see the right ventricle, the right atrium, and then surrounding everything is this white fluid. There's also some fluid in the pleural space underneath the lung on the left side. There's a little bit on the lung on the right side. It may be physiologic. There's fat. There's fat around the heart, which is where the epicardium is, and the epicardial coronary vessels are embedded in the fat. And then there's a parietal pericardium and then a visceral pericardium, and then there's the sac. So you can see this very well. You can see the heart is doing the backstroke. So we'll show you a couple more images. Hang on. And this is another image showing the myocardium and a fluid-filled space around the heart. And we see lighting up of the pericardium where it's actually white. And then we see the epicardium, the space, the shear surface is white. So this white represents acute active pericarditis, to make the tissue actually have this gadolinium appearance of late gadolinium uptake of contrast. And so that diagnosis and clinches the diagnosis of acute pericarditis. Send it back to you. Hang on. I'll briefly tell you one more case, and then show you the CT scan of the other case. Hang on. So we show you ultrasound and then CT. And so this is a gentleman who had upper respiratory infection. This is the pericardial space. This is the fluid. This big black space here is the fluid. This is the epicardial surface of the right ventricle. And you can see all the fluid that's surrounding the heart all the way around, both sides. Anteriorly, this patient's on his back. That's a subxiphoid view. Again, you can see pericardial space is filled with fluid, and we can measure that in terms of centimeters. Let me show you the CT. And so you can see how different this image, which is a CT image, you can tell it's a CT because of the density of bone. Bone is very white on a CT, but not on an MRI. And then instead of seeing the black space, now you see a fluid-filled space that looks different, and we can give you Hounsfield units for density, and we can measure that. Hang on. There we go. So this is the density of water, fluid, -17, -6, 9, 0. So it's all revolving around 0. You can see bone gets up to 1,000. There's 964 on bone. You can go over to air. Air goes up to -1,000. There's -907. And so what's neutral is water. It's been declared neutral, and so here's -16, here's +16. So revolving around the density of water. And so here's the large pericardial effusion. Person's lying on their back, so the fluid is mostly posterior. Here's the heart. The heart looks great. Myocardium. This is a big space. Everything else looks anatomically intact. So in conclusion, this patient is a large pericardial effusion. He's gone into the subacute chronic phase, and now we're deciding how to treat him more aggressively. He's been on NSAID. He's a 63-year-old gentleman who had an upper respiratory infection. He's been on NSAID. He's been on some colchicine. Now he's on more regular doses. And what we'll probably be doing is getting the radiologist to, under CT guided, put a needle in there, remove the fluid, and then see if it reaccumulates. And so that's our plan. So in conclusion, acute pericarditis has a pretty obvious presentation. The spectrum of disease can be acute viral is the most common. We showed acute, subacute. We showed chronic pericardial effusion associated with that. The treatment, NSAIDs, colchicine, steroid use is questionable. Invasive evaluation if needed in terms of removing the fluid, creating a window, or putting a needle in with CT guidance. We talked about acute tubercular, which is very rare. We talked about acute bacterial. I've seen one of each in my career. The viral is the most common, and what we'll see encounter in the emergency room, the recognition of it, the pericardial rub, the EKG changes that become very classic, and then the evolving EKG changes that occur with T-wave inversions as it moves into a subacute phase, differentiating that from an acute MI and using your echo as a guide, and recognizing acute pericarditis with an MRI, with lighting up of the pericardium, recognition of the fluid again, CT scan recognition of the fluid, because people frequently get triple rule outs for dissecting aneurysms, pulmonary emboli, and coronary artery disease, and it actually becomes a quadruple rule out in terms of ruling out pericardial disease. We see it a lot in oncology. We see it a lot in chronic kidney disease with uremia. So thank you very much. That concludes our presentation today. Another presentation, we'll be talking about chronic recurrent pericarditis and constrictive pericarditis. Have a good day. Bye-bye.
Thank you.
Thank you, Pooh.
Yeah, thank you. Bye. Have a good day.
Have a good day.